Hi, this is Rob Fitzgerald. Welcome to Quick Hits in Laboratory Medicine. This is my first recording in the COVID era, so I figured I would don the mask, but that probably won't work so good, at least acknowledging the fact that most of us are wearing masks today. We're going to be talking about biomarkers of heart failure, the natriuretic peptides in particular. Heart failure is a complex clinical syndrome, affects about 500,000 U.S. patients a year, a very high readmission rate in this patient population, so difficult patients to take care of, and the laboratory has made a contribution in the natriuretic peptides, which actually first came to be used here in San Diego at the VA hospital, based on a local biotech company, Biosignature Diagnostics, who first developed the natriuretic peptides. Clinically, heart failure is characterized by shortness of breath, dyspnea, fatigue, and fluid buildup. So those are sort of the hallmark characteristics. And it's really caused by the inability of the heart to supply enough blood to oxygenate normal physiological processes. So a quick review of blood flow. Blood comes in from the periphery into the inferior and superior vena cavas into the right side of the heart. And so the right side of the heart in systole, in the contraction, is going to pump blood out through the pulmonary arteries to the lungs, where it's going to get oxygenated. It's going to come back in the pulmonary veins into the left side of the heart. And when the heart contracts again, it's going to express blood through the aorta and out to the periphery. So the right heart pumps to the lungs, and the left heart pumps to the periphery. And natriuretic peptides are primarily useful for left-sided heart failure, so systolic dysfunction. We think of the heart as a many different ways, but one way is as a pump. And clearly that is one of its main physiologic roles. It's also an endocrine organ, and it is having an impact on fluid status through its interaction with the kidneys, and it does that through the natriuretic peptides. So there's 3 different natriuretic peptides: ANP, A-type natriuretic peptide, B-type natriuretic peptide, and C-type natriuretic peptide. Primarily in a clinical diagnostic setting, we use the B-type natriuretic peptide and related molecules. So natriuresis, Na is sodium. Natriuresis means excretion of sodium. And so essentially the take-home message is that natriuretic peptides are stretch markers. They are volume overload signals. So when the heart gets stretched, the muscle fibers don't overlap very well and they don't pump efficiently. The heart senses that and releases natriuretic peptides. So natriuresis is acting on the kidney to excrete sodium. Sodium takes along with it fluid, so it causes a diuresis and is going to decrease the fluid load coming into the heart, so that the heart can, the muscle fibers can overlap appropriately and get better contraction. It also has inhibiting effects on renin, angiotensin, aldosterone. So those are sort of direct effects. What's happening in the kidney in the setting of heart failure is there's insufficient blood flow because the heart's not contracting appropriately. And the kidney says, okay, we need more fluid. And so the kidney is going to release renin. Renin is sensitive to GFR, and renin is going to stimulate the angiotensin aldosterone system, with the end result being that aldosterone is going to act to reabsorb sodium and bicarb. Primarily sodium is going to be bringing with it water, so you're going to increase the volume status. It's going to be antidiuretic, and it's going to be vasoconstricting. So those are sort of in direct opposite of what the heart's trying to do, and that's when patients become decompensated. So BNP is the biosignature of heart failure, and it is synthesized as a pro-molecule. So it's 108 amino acids, and it has this natriuretic peptide ring. This ring is connected by a disulfide bond, and that's shared by all of the natriuretic peptides, they have a little bit different amino acid sequence, but they share this central ring with a disulfide bond. In the setting of volume overload, the myocytes actually release this compound, and there's an enzyme called corin. Corin splits the enzyme into two different fragments. One is a 32 amino acid BNP, and this is the active hormone that is going to cause natriuresis. So has a fairly short half-life. The other component is the amino terminus of that polypeptide protein, 76 amino acid fragment. This is an inactive fragment. And in the laboratory, there are two different tests. We call this one N-terminal BNP, or NT-pro-BNP is the common term for that. And this one is simply termed BNP. And so different laboratories will offer, one lab might offer an NT-pro-BNP, whereas another laboratory would offer a BNP. Both of these markers are good for diagnosis of heart failure. They have different reference ranges, and there's some slight differences, but if you look at the data objectively, both of these markers work very well in the setting of heart failure. So the take-home message that I'm trying to get across is that the natriuretic peptides are secreted in response to ventricular overload and volume expansion, and they are trying to decrease the volume so that you get better contraction. These are reference ranges for the different tests, and you'll notice that BNP has a single reference range, and it's less than 100 picograms per mil, whereas NT-pro, the reference range actually changes according to age. And so these are what we call the icon cut points. These are from several different international studies. In fact, BNP also has age adjustments, but it was approved by the FDA before we realized that. And so there's a single cut point, but in reality, both of these markers change with age. So just a general reminder, drugs can affect different lab values, and this is a sort of a classic example. Entresto is a heart failure drug that was approved in 2015. It was one of the largest clinical trials, 8,000 patients around the world, really had positive results. An interesting mechanism of action. It was new to the time in heart failure. Heart failure, there's lots of different drugs with different mechanisms of action that get used. This one combined a neprilysin inhibitor. Neprilysin is the enzyme that breaks down the active BNP molecule. And so if we inhibit that enzyme, you have BNP that sticks around longer, and it's going to cause the natriuresis, and you're going to decrease the volume overload and allow the heart to pump it more effectively. It also is combined with an ARB, an angiotensin receptor blocker, and so those two are going to combine different components of treating heart failure, and it was effective in many of the primary as well as secondary outcomes in the initial trial. What's interesting, and the reason why I'm mentioning Entresto in particular, is that in the setting of patients who are on Entresto, you're going to expect their BNP to be high. That's an effect of the drug and not an effect of the disease. And so that's something that you need to think about if you're ordering a natriuretic peptide on your patients and whether or not they're taking Entresto. Is their BNP high because their heart failure is bad, or is their BNP high because Entresto is working? And again, that's true with many different lab tests and needs to be thought of. And thanks again for tuning in to another quick hit in lab medicine.